The profession of anesthesia demands that the certified registered nurse anesthetist is an expert at airway management. Patient safety depends on the clinician's thorough understanding of anatomy, management techniques, equipment, and possible complications. This is the first of 4 lectures for the Difficult Airway Simulation Workshop, which will take place on Monday, November 9th. There is a short quiz that goes along with each lecture. Feel free to print it and fill it out as you go through the lectures. Please bring all 4 completed quizzes with you to the workshop. These are the objectives for the lectures and the in-person workshop. To increase students' knowledge of airway anatomy and assessment techniques, to increase students' knowledge of airway management planning, to increase students' skills in the use of alternative airway management equipment, to increase students' confidence in their ability to manage a patient with a difficult airway, to demonstrate students' competence in the management of a patient with a difficult airway with the use of simulation. The American Society of Anesthesiologists created a closed claims database in 1985 to identify major safety concerns, patterns of injury, and strategies for prevention to improve patient safety related to anesthesia. The database contains over 8,954 claims, and while it lacks the data of the total number of anesthesia cases performed from which the claims arose, trends in malpractice claims data appear to correspond to trends in anesthesia practice. Data collected from 1990 to 2007 show that some of the most common damaging events due to anesthesia were respiratory in nature. Of these, 27% were related to difficult airways. These types of events have the potential to lead to substantial morbidity and mortality. Some of the most serious outcomes observed from these data were death, permanent brain damage, and airway injury. In nearly half of the difficult airway claims, care was judged to be less than appropriate, and payment had to be made in more than half of the cases. The median payment for a case involving death or permanent brain damage was $424,000, while the median payment for severe injury was $72,333. As cited in the Standards for Accreditation of Nurse Anesthesia Educational Programs in 2013, graduates must be able to use a variety of current anesthesia techniques and equipment while providing anesthesia, and function as a resource person for airway and ventilator management of patients. To be eligible to test for board certification, students must have logged a minimum of 10, but preferably 40 alternative airway management techniques, including fiber optic intubation, light wand, retrograde tracheal intubation, combat tube, transtracheal jet ventilation, gum elastic bougie, tracheal tube changers, esophageal obturator airways, LMA guided intubation, and cricothyrotomy. The graduating class of 2013 at the University of Cincinnati satisfied all minimum requirements, but many did not perform all the suggestive alternative airway management techniques or meet the preferred standards. This will be a short review of the airway anatomy that you learned at the beginning of the program. There are 2 openings to the human airway, the nose, which leads to the nasopharynx, and the mouth, which leads to the oropharynx. They are separated anteriorly by the palate and joined posteriorly in the pharynx. At the base of the tongue, the epiglottis separates the oropharynx from the laryngopharynx. It is the job of the epiglottis to prevent aspiration by covering the glottis or the opening of the larynx during swallowing. The larynx is composed of 9 cartilages, the thyroid, cricoid, epiglottic, and in pairs the arytenoid, corniculate, and cuneiform. The nerve supply to the airway is complex, but important to understand when deciding how to topicalize for awake fiber optic intubations. The lingual nerve, a branch of the trigeminal nerve, provides sensation to the anterior 2/3 of the tongue. The glossopharyngeal nerve innervates the posterior third of the tongue, the tonsils, and the undersurface of the soft palate. The vagus nerve provides sensation to the airway below the epiglottis. The superior laryngeal branch of the vagus divides into an external motor nerve and an internal sensory laryngeal nerve that provides sensory supply to the larynx between the epiglottis and the vocal cords. Another branch of the vagus, the recurrent laryngeal nerve, innervates the larynx below the vocal cords and the trachea. All of the muscles of the larynx are innervated by a recurrent laryngeal nerve except for the cricothyroid muscle. It is innervated by the external laryngeal nerve, a motor branch of the superior laryngeal nerve. The blood supply of the larynx is derived from the branches of the thyroid arteries. The cricothyroid artery crosses the upper cricothyroid membrane and extends from the cricoid cartilage to the thyroid cartilage. The superior thyroid artery is found along the lateral edge of the cricothyroid membrane. When performing a cricothyrotomy, the cricothyroid and thyroid arteries rarely affect practice, but it's best to stay midline, midway between the cricoid and thyroid cartilages. When interviewing a patient, a detailed and focused history and physical of the airway is an important step. The history portion includes talking to the patient about past incidences of difficult intubation and acute or chronic diseases or syndromes that could affect their airway or your ability to intubate them. Conditions that are associated with difficult intubations include, but are not limited to, tumors, hemangiomas, hematomas, submandibular abscesses, epiglottitis, foreign bodies, trauma to the laryngeal structures or mandible, rheumatoid arthritis, diabetes, cervical spine injuries, and halo attraction. Syndromes that are associated with difficult intubations include Pierre-Robin, Treacher-Collins, laryngeal atresia, Goldenhar syndrome, Down syndrome, and craniofacial dystocias. Sometimes when looking at the patient, it is obvious that problems may arise during intubation. With other diseases such as arthritis or diabetes, you may not know that the patient has them and therefore has the potential for difficult intubation without discovering this information in the interview. There are multiple physical characteristics that should be assessed in order to identify the potential for airway problems. The Mallampati classification is an indirect method of relating the size of the base of the tongue to the oral cavity. With the Mallampati 1, you can see the soft palate, uvula, and anterior and posterior tonsillar pillars, and will probably have an easy intimation. With the 2, you see the same except for the tonsillar pillars are hidden by the tongue, and the intubation could be possibly difficult. With the Mallampati 3, only the base of the uvula is seen, and the intubation will probably be difficult. Even the uvula is not visualized with the Mallampati 4, and intubation will be very difficult. While no measurement has proven in the literature to predict a difficult airway on its own, by combining Mallampati scores and thyromental distances with mouth opening, neck circumference, and head and neck extension, we have a better idea of the potential for a difficulty ventilating and intubating our patients. Other things that we look at during our physical assessment include body weight, facial hair, and dentition. Before we can make an airway management plan, we must think about the ease of which we'll be able to ventilate, intubate, or perform a cricothyrotomy. Difficult mask ventilation is seen with poor mask seal, male gender, obesity, obstruction, age over 55, edentulous patients, a history of neck radiation, and the presence of facial hair. Ventilation is also challenging in the presence of an increased ventilatory pressures that can be found with asthma, COPD, ARDS, and term pregnancy. Difficult laryngoscopy is found with patients who have a higher Mallampati score, obstructions, obesity, decreased neck mobility, decreased mouth opening, and sleep apnea. We also see it when the patient has an anterior airway, which is often predicted by measuring a short thyromental distance. If a patient is unable to be ventilated or intubated, then a surgical airway must be performed. The ease of this should be considered when developing a plan. Difficult cricothyrotomy is often seen in patients who have had previous neck surgery, tumors, infections, obesity, or previous radiation. When deciding on a plan for the management of your patient's airway, there are several questions that need answering. First, does the operation necessitate a controlled airway? If not, then you should consider regional anesthesia. If it does, then you have to ask yourself if a direct laryngoscopy will be difficult. No to this means you should be able to proceed with intubation attempts after the induction of anesthesia. If you suspect difficulty, then you need to know if you'll be able to ventilate the patient. If not, consider awake fiber optic intubation. If ventilation is possible, determine if the patient has an empty stomach. If they are at increased risk for aspiration, consider awake fiber optic intubation. If not, decide whether or not the patient can tolerate periods of apnea. If they cannot tolerate apnea, they need an awake fiber optic intubation. If they can, then it's okay to consider intubation after the induction of anesthesia. This is the end of the first lecture. Please remember to bring your quizzes to the workshop on Monday.